dear friends. This is Dr. Aishvarya Kaushik. And starting with today's session, we are discussing previous year questions from endodontics and conservative dentistry. I've come with a mixed bag, some confusing questions, some okay, relatively easy questions because, 1 month is left for the exam, right? Whether the question is tough, whether the question is easy, whether the question is mid-level, they all carry the same marks, right? And as I always say, last 1 month, just concentrate on the previous year's questions and the topics. Do as many MCQs as possible, guys. And with this endeavor, with this sentiment, we're going to start with today's session, guys. So we are with the previous year questions from endodontics and conservative dentistry. Right, guys? All right. Obviously, as always, with the question, we are going to discuss the related concepts and whatever possible, confusing questions that the examiner can corner you into, right? So Wien's type 2 classification of root canal means, very easy question. You know why? Because Wien's type 2 and Wertucci type 2 is the same. I always say this, guys, and I'm going to repeat this. The moment you see the question, do not see the options, except for those questions in which all of the following are true, except. Obviously, your answer is going to be from the options. But here, a very objective, very precise question has been asked, which is basically quizzing you about your knowledge, right? So Wien's type 2 classification, immediately go to your, scribbling page. First of all, because Wertucci is the more often asked, so first we will write down Wertucci, then we write down Wien, and we compare and try to generalize as to what is common between them, what is different, right? So Wertucci type 1, 2, 3, 4, 5, 6, 7 and 8, right? And we talk of Wien, it's actually 1, 2, 3 and 4, right, guys? So Wertucci type 1 is simple one single canal throughout. When you've written 1, on the left hand side write, if there's 1 then write 2, if there's 2 then write 1. So we have 1, so you write 2 with 1. Type 3, so you write what is there in type 2, so 1 and 2, and on the left hand side, if there is 2, write 1. So 1, 2, 1. Type 4 is an exception here from this trend, right? Here, type 4 is simply 4 divided by 2. So 2 canals throughout. Wertucci type 5, again, same trend, 2, and then on the left hand side, write 1 if 2 is present. Type 6, again, repeat what is type 5, and then on the left hand side, write 2 if 1 is present. So 2, 1, 2. Type 7, the trend continues. So 2, 1, 2, and then on the left hand side, write 1 if 2 is present. Now type 8, again, the trend breaks, right? The trend breaks in type 8 and there are 3 canals throughout, right, guys? So that's Wertucci, right? First, write this down, and if the examiner asks you what is Wertucci type 5, what is Wertucci type 3, then you have to match it from this. Don't get confused with the options. Excellent. Then Wien. Now, Wien is relatively less categories. So 1 is simple, is the same as Wertucci type 1. That's 1 canal throughout. Right? Type 2 is again the same as Wertucci type 2. That's 2 with 1. Right? Now, the difference is with type 3 and 4. Type 3 is 2 canals throughout. So type 3 of Wien is the same as type 4 of Wertucci. Right, guys? Then type 4 of Wien is 1 dividing into 2. So type 4 of Wien is the same as type 5 of Wertucci, guys. Right? So this solves all your questions. Now, Gulabi wala, nobody's going to ask. So I'm just going to, write this down here. Don't waste your time in memorizing Gulabi Wala's classification, right? So they've asked you what Wien type 2. It's simple. Wien's type 2, the answer is 2 merging into 1. So what do we have? The options: 2 orifices, 2 canals, and 1 foramen, right? So the answer is A. Correct answer is A, guys. Right, my dear friends? Is that clear? Wien Bertucci has to be memorized. Make a mental note of it. Write it down on a rough piece of paper, whatever is given in your examination. Match it with the options. Mark the right answer. Again, another tip, since we are just, in the exam going weather or phase, never ever, even if you're very sure of the answer, never ever mark on the first go. First read. Read the question, arrive at the right answer, go to the next question, arrive at the right answer. At least do this for half the paper. And then in the second go, start marking the answers for which you are 100% sure. Right, guys? Time is never a problem. You're not solving, complex maths and physics problems or inorganic questions of chemistry, right? Right, guys? How much minimal loss of subsurface enamel is required to be visible on the radiograph? Again, hardcore theory-based question. The ideal answer to this is actually 400. This has become too thick. So the ideal answer is 400 microns, guys. Now, 400 microns is very intelligently omitted by the examiner. So the next best answer is 500 microns. Right, dears? Composition of Gatta Parcha in GP. See, guys, this is a relatively simple question. Why have I put this here? Paradoxically, Gatta Parcha in Gatta Parcha is very less. So it's only 20% by weight GP. And about 60 to 65% is actually zinc oxide, guys. So the other MCQ that comes is, which is the main constituent by weight in Gatta Parcha? So there the answer is zinc oxide. Now, as far as Gatta Parcha is concerned, I'm not, I want to add some more value to this question. So I'm going to tell you a couple of another important points about which I'm sure most of you have forgotten by now. Although we've done this in rapid revision, we've done this in live classes, we've done this in recordings, but I know, many of you must have forgotten this. So I want to quickly revise that. So guys, Gatta Parcha number 1 is naturally, how is it obtained from the tree? It's a isomer, trans isomer of polyisoprene, and the natural product is in the form of alpha form, right? Then it is in the factory, or it is, modified during the manufacturing process to get it converted into beta form. That's number 1. So basically, the two crystalline phases of Gatta Parcha in which it exists is alpha and beta. Number 1 point. So that's one thing. Second, for cold lateral compaction technique, beta form is preferred because it is compactable, more compactable. For warm obturation techniques, alpha form is preferred. Why? Because once the alpha form is heated and when it is cooled, the shrinkage is less. Now, what are the warm obturation techniques? Warm vertical compaction, continuous wave of compaction, the thermoplasticized technique, right? And obviously the carrier techniques like thermafill and simplifill, right? I'm not going to go into the details of these. We've done this in much detail in our recordings and live and rapid revision and TND, etc. Then next, very important, the transformations based on temperature variations. So based on temperature variations, the transformations of phases. Now, there are two very important things. One is 46 degrees Celsius. That's one. Second is 64 degrees Celsius, or in some texts, it's written just 65 degrees Celsius. So more or less the same, right? So when you heat the gutta percha at 46 degrees Celsius, the beta form changes into the alpha form, right? Then when you heat it from 54 to 60 degrees Celsius, memorize these transformation changes based on temperature. The alpha crystalline phase turns into the amorphous alpha phase. When you further heat it to 64 degrees Celsius, guys, the alpha phase melts. Right? So guys, please memorize these transformations, temperature transformations. So where we started was a simple question where we discussed two MCQs, the composition of or the percentage by weight of gutta percha and gutta percha. That's just 20%. The next MCQ is what is the maximum content of gutta percha in gutta percha? What component? Zinc oxide. That's about 60 to 65%. From there, we jumped on to these related MCQs. I want you to maintain this pattern while you're revising. So with one question, you end up revising 8 MCQs. Right, guys? Excellent. Angle former. This is again a question which gives a lot of heartburn to all of us when we always get confused between the cutting instruments, which are excavators and chisels. So the moment you see angle former, don't see the options. Right, guys? The moment you see the angle former, don't see the options. Directly go to your rough page and make a note of basically your classification of hand cutting instruments. So your hand cutting instruments are your excavators and chisels. Excavators is very confusing. Number one, ordinary hatchet, which is also known as the beveled hatchet. Now this is a hatchet, but this is an excavator. When you talk of chisels, the enamel hatchet is a chisel, but an ordinary or bi-beveled hatchet is an excavator. Then your hoe, your angle former, and your spoon excavator. These are your excavators, right? So you made a list of this. Chisels, what are the chisels? Straight chisel, curved chisel, or the Wedelstedt chisel. Right? Then you can have a, the enamel hatchet, and you have the gingival marginal trimmer. So that's your list, guys, of excavators and chisels. Now you go to the question. What is the question asking us? Angle former. What is the angle former? Refer to your table which you've made yourself. So the angle former is an excavator. Right, guys? This is how you will never get a repeat question wrong. Right? That's a systematic way of minimizing your negatives. So angle former is an excavator, guys. Again, confusion. What is the first number in a 4-digit instrument formula denoted? Usually you will mark it right because that's simple, 1/10 of a millimeter. But where you get confused is 3-digit instrument formula, 4-digit instrument formula, the first, second, third, and fourth places. Right? So I'll tell you a simple way. We talk of the instrument formula, guys. There's the first digit. Then we have another place. Then we have another place. Right? So the first is the width of the blade in 1/10 of a millimeter. Then forget about the first, second, or third places. Then you write, because we're talking of the blade, right? So we've written the width, then the length of the blade, isn't it? It's obvious, isn't it? Then we write the length of the blade. So blade is done, right? As far as the measurement, linear measurements are concerned. Then next is the blade angle. Right? Now this is the formula for a 3-digit instrument. First place, second place, third place. Right? Now, when you're talking of a 4-digit instrument, guys, then what is the formula? In the place next to the first place. In the place next to the first place, add cutting edge angle. Right, guys? Add cutting edge angle. So what does this become? For a 4-digit instrument formula, the instrument formula would be the first place, width of the blade, second place, cutting edge angle, the third place, length of the blade, and the fourth place, the blade angle. Right, guys? So first write the 3-digit instrument formula, and in the place next to the first place, on the first right-hand side, insert the cutting edge angle. And then just write it 1, 2, 3, 4 from left to right. That is the places of the 4-digit instrument formula. And this is for 3-digit instrument. Is this clear? So this makes your life simple, right? So once you write this down, now anybody can ask you, okay, what is the third place in a 3-digit instrument formula? That's a blade angle. But what is the third place in a 4-digit instrument formula? The third place in a 4-digit instrument formula is the length of the blade. Right? So if you mark this like this, then you can never get it wrong. All right, my dear friends, is this clear? Excellent. Wonderful. All right. Next. On performing percussion on teeth in the oral cavity, the response is painful, guys. The most likely diagnosis. Now just forget about everything else. This is a diagnosis of the PDL. There is tenderness on percussion. It is apical periodontitis, and it is because it is painful, so it's acute apical periodontitis. Acute apical periodontitis. Now, in this, very important. So this is okay. So this answer is done. So it's symptomatic apical periodontitis, acute, or a better answer is symptomatic apical periodontitis. Right, guys? Next important point regarding symptomatic apical periodontitis. I'm just giving you more points. The tooth can be vital. It can be non-vital. Always remember this, guys. Why? Because you have a tooth in which the caries is like encroaching onto the pulp space, but the tooth is still vital, right? So what happens is sometimes the inflammatory mediators, they do go into the PDL space with the tooth still vital, right? And they cause tenderness to percussion. So the tooth can be vital, non-vital. Then there is PDL widening, or there might not be PDL widening in the initial stages. Right, guys? That is the difference between a symptomatic apical periodontitis versus an acute apical or periapical abscess. Why? Because the tooth here will always be non-vital. And there will always be a periapical radiolucency, which can manifest as simply widening of the PDL or slightly bigger radiolucency. But there will be. The periodontium will not be normal on the radiograph. Right, guys? So always non-vital clinically, and radiographically, there will be radiolucency, which would obviously be hazy and ill-defined in the periapical area, or simply widening of the PDL, right, guys? That is why I put this question. There's a lot of confusion going on amongst you between, the clinical presentation, the clinical findings in symptomatic apical periodontitis versus acute apical abscess. Symptomatic apical periodontitis, obviously, it can be as a sequel to pulpal necrosis. So in that case, the tooth would be non-vital, but the tooth can be vital as well. But with acute apical abscess, the tooth will always be non-vital, period. Right, guys? Great. Moving on. Which of the following is not a supplemental injection for endodontic treatment, guys? So what are the supplemental injections that we have? We have the intraligamentary, we have the intraosseous, and we have the intrapulpal. So any injection which is the main injection, like an inferior alveolar nerve block, posterior superior alveolar nerve block, incisive nerve block, infraorbital nerve block, they are not supplemental. They are the main LA techniques, right? So the answer is simple here. The IANB is not a supplemental injection for endodontic treatment. Right, guys? Now this question, which of the following is not a retrograde root end filling material? Now, guys, this is a direct pick from Cohen. There are a lot of materials which Cohen enumerates as root end filling materials. Just in case you're not able to remember them, for example, I'll give you an example. Like you have retroplast. It's a resin-based, composite-based material for retrograde filling. Then you have obviously your calcium silicate-based cements like MTA, etc. Right? And so on and so forth. So in this is a relatively easy question in the sense that, if you just see the options, you have endomethasone, and endomethasone is basically a sealer. This all of us know. Right, guys? So the moment you see this is a sealer which you use with gutta percha. Obviously, nowadays it's contraindicated because it consists of formaldehyde or paraformaldehyde. So presently it's contraindicated, but it was never used as a root end filling material. So that's one aspect of this question. I wanted to add value here. Again, I've taken out a very important and confusing point for you guys, which all of you find confusing. And what is that? When you talk of root, see what happens in surgery. We're talking of root end filling, right? So you have a tooth, right, which with the help of periapical surgery, you've resected the apical third of the root. Now you make so what do we have here? So you resected this, right? Now we make a retrocavity prep, a simple class 1. With the help of earlier, we used to have burrs. Now we do it with ultrasonic tips to be more conservative. And then we do a retrograde filling. Now, before that, you also want to do what is known as root end conditioning. What is root end conditioning, guys? Root end conditioning is basically a material, a weak acid, which is applied at the root end so as to promote cementogenesis, so as to create conditions which would expose the collagen in the dentine of the root end and would help in better, cementogenesis of the root end. Now, for this, 3 materials are used, usually EDTA, citric acid, and tetracycline. Out of which EDTA is the preferred material. Number 1 MCQ for root end conditioning. However, now an applied MCQ is coming your way, guys. Listen to this very carefully. Whenever you have to use MTA as the root end filling material, never use EDTA as the root end conditioning material. Why? Because it interferes with the hard tissue formation effect of MTA. So star marked MCQ, whenever MTA is to be used as the root end filling material, do not use EDTA as the root end conditioning material. Is this clear, guys? Why? Because it interferes with the hard tissue formation effects of MTA. That's a star marked MCQ. Excellent. Now, another important question from your diagnosis: which of the following is most reliable for cold vitality test? So, what are the various ways in which you can do the cold vitality test, guys? Cold water, ice, refrigerant spray, then 1,1,1,2 tetra fluoroethane or chlorofluoroethane, which is because of the CFs, because of the bad effect of chlorofluorocarbons on the ozone layer. Usually they have been replaced with tetrafluorocarbons, right? That's why I've written tetrafluoroethane. And you can use dry ice, which is nothing but liquid carbon dioxide or carbon dioxide spray. Right, guys? All of them are good. But which one will give you the effect or the response sooner than others? The one which is the most cold? The most cold is dry ice, guys. Because the temperature varies from minus 60 degrees Celsius to around minus 98 degrees Celsius. In some references, it's written as somewhere around minus 72 degrees Celsius. So the range is the same. That is minus 60 to minus 98, right? So the range is minus 60 degrees Celsius to minus 98 degrees Celsius, right? The temperature of the 1,1,1,2 tetrafluoroethane is around minus 26.2 degrees Celsius. That is also good. That's great. But you would prefer a liquid carbon dioxide in terms of the faster effect, faster result that it gives you. Right, guys? Is that clear? Yes? I hope you're getting good revision, overall revision of all the topics here. Wonderful. All right. Now, in an access cavity prep, if the cavity has not extended until the canal is clearly disclosed and the canal remains. Okay, just a sec. I'll just first of all mark the right answer here. Carbon dioxide snow. Right. Next question. In an access cavity prep, if the cavity is not extended until the canal is clearly disclosed and the canal remains in the lateral wall of the access cavity, the appearance resembles that of. Now, guys, basically what he's saying is, that's your tooth. That's your cavity prep, pretty nice, but slightly underextended, meaning your orifice, which should have been right at the completely on the floor of the pulp chamber, you've basically compromised on the lateral extension. So the orifice here is partially on the floor and partially on the wall. Now this prevents straight line access. To the primary curvature in curved canals or to the apical foramen in straight canals, right? Because your file is going to go teda. It's going to go at an angle, right? Not going to go straight. It's going to go at an angle. And that would put more pressure on the file. So file can break, number one. Second, it can transport the canal because on the outer curvature, you're going to put more pressure. That's the applied part of this question. Now, how does this look like? This appearance resembles a mouse hole. Nowadays, we're very careful with these things, but when we were kids, I used to live in an area where, mice, rats kept coming in and out. We used to live in Railway Colony and, we had a jungle, behind in the backyard, almost a jungle. I mean, wild place. So mice would keep coming, and I had a free run, right? It's an open house for them. So mice have this tendency to kind of go at the line angles and the point angles, right, at the junction of the floor and wall, and dig holes. So that's the mouse hole effect, right, guys? So that's the answer here. Mouse hole, right? All right. Now we have got a good question, applied question from chromatology. I hope this is visible now. Yeah. A young lady came to the dental clinic with subluxation. Now, subluxation is the key word here, of maxillary anterior tooth, number one. That's a complex question in the sense that there's an avulsion injury as well as another injury. What is that? She suffered trauma due to fall. Okay, obviously. She has to suffer trauma to undergo a avulsion injury. X-ray shows horizontal root fracture of the apical third. How will you manage? So let us just look at the management of these two individually. What is the management of subluxation? Really nothing. Subluxation is basically wait and watch, but for the comfort of the patient, you can splint. What splint? Flexible splint or semi-rigid splint, right? Or physiological splinting for up to 2 weeks, right? For patient comfort. What is the management of root fracture in the apical third? Nothing. Again, wait and watch. So the management of root fracture in the apical third is wait and watch. So what are the options closest to this? Actually, you could have as the answer no treatment required because you're just doing waiting and watching, or splint and observe routinely for vitality. Now, guys, here we would go for splint and observe routinely for vitality. You know why? When no treatment required is something like, I mean, you just left the patient without even calling her for follow-up. Any traumatic injury, even if it's a concussion injury, which is the mildest of avulsion injuries, it's even milder than subluxation. You have to call the patient 3 weeks, 6 months, 3 weeks, 6 weeks, 3 months, 6 months, 12 months, and yearly thereafter for the evaluation of vitality. So the better answer here is Splint and observe routinely for vitality, guys. Right? That's why I put this question. The question is simple. The options are confusing. Right. Excellent. Which of the following is true for Gatta Parcha cones? Again, a question from Gatta Parcha. Now, this is simple. Again, this is an answer of exclusion, so we have to look at the options. They can be heat sterilized? No, they cannot be. They have to be sterilized in by dipping them or immersing them in 5.25% sodium hypochlorite for 1 minute. Color coded to denote size? Yes, that's the right option. Your yellow would be 20, your white would be 15, your 25 would be red, and so on and so forth. So basically, the color coding corresponds to the color coding of the files and the reamers. 50% content is Gatta Parcha, again wrong. We just discussed this, only 20%. Chemically bonds to dentinal walls? Absolutely not. The only situation in which the Gatta Parcha has the potential to chemically bond with the dentinal wall is active GP, in which you're coating the GP with GIC, right? That's the only possibility. But in general, Gatta Parcha, they do not bond to dentinal walls in general. All are true for Gates Glidden drill except. Now, Gates Glidden drill, what are the questions that come here? You have this, flame-shaped anatomy of the Gates Glidden drill. The end is non-cutting. They are used to prepare only the straight portions of the canal, never used in the curved portions of the canal. They are used as orifice enlargers and up to an extent for the pre-enlargement of the coronal third of the root canal. They come according to their tip diameter. They come in sizes from size 1 to 6. Right. Then what else? The end is non-cutting. Right. And another question that they sometimes ask you is about the dimensions, from 1 to 6. What is the diameter? That question we've discussed many a times in rapid revision, also in TND. So please remember those, like 1, 2, 0.5, 1, 1.5, and so on. 0.57, 0.7, then 0.9, then 1.1, 1.3, and 1.5. That's the tip diameter of sizes 1 to 6, right? So we have, what do we have? I'll just revise this. 0.5 mm, 0.7, 0.9, 1.1, 1.3, and 1.5. So they would simply ask you guys, what is the size of, what is the tip diameter of GG drill number 3? So the answer is 0.9. Or what is the size of a GG drill number 4? So the answer would be 1.1, right? So there are a lot of questions coming from GG drills. Next important question. They are always, activated on the outstroke. So you passively insert them inside the root canal. And on the outstroke, you have to brush them against the walls of the canal. Right, guys? So anyways, we now know the theory. What is the answer? It is an end cutting instrument. That's the wrong statement. So that's the answer. Let's look at the other options. We've discussed them. They are available from sizes 1 to 6. Discuss that. Used to enlarge the coronal part of canals. Absolutely true. Used in only the straight portion of the root canals. Absolutely true. What is the acceptable runout of burr? Now, guys, this is an absolute theory-based question based on two related concepts of, we've discussed this before, concentricity and run out, right? So concentricity is a static parameter of the burr symmetry, right? Absolutely ideal, perfect in the cross-sectional diameter. Run out is where the burr is going perfectly symmetrical when it's running. Now, in practicality, the best of the best burrs and handpieces do not have zero run out. Ideally, they should have zero run out, right? So what is the upper limit of run out or the lateral movement in the burr while it is rotating at high speeds? What is the acceptable upper limit? That answer is 0.23 millimeters. That's the answer. Memorize this, guys. And I've already told you the related questions, concentricity and runout, right? This device is used for both placement and removal of rubber dam clamp, right? So basically, it's the rubber dam clamp forceps. Simple answer. So what do we have? We have the rubber dam frame. In the rubber dam, what do we have? We have the rubber dam frame, right? We have the rubber dam sheet. We have the clamp. We have the clamp forceps, right? So just to tell you certain other questions, applied questions. That's the clamp, right? That's the bow of the clamp. Now, always to ensure that the bow does not get dropped accidentally into the oral cavity and the patient does not, swallow it or aspirate it, you always tie it with a floss or dental tape. What is the length of the floss which is used to secure the rubber dam clamp? That's about 12 inches, which is about 30.5 centimeter. Right, guys? That's one. Second, when you have a dentition, right, like this, the central incisor, lateral, canine, premolars, 6, 7. So when you're doing, quadrant dentistry and you're placing holes on the rubber dam sheet, what is the distance at which you place the holes? That distance is the same as the distance from the center of one tooth to the center of the other tooth. And that is roughly 1/4 of an inch, which is equal to 6 millimeters roughly. These are important values which should be memorized. Right, guys? Then the next MCQ from rubber dam. When you're doing RCT, meaning for endodontics, you do only single tooth isolation, right? Only isolate the tooth with the rubber dam on which you're performing the root canal treatment. But for restorative work, for filling, that is restorative. When you're working on incisors and the mesial surface of canine, isolate from first premolar to first premolar. Number 1 point. Next, when you're working on the other areas of canine like the lingual surface or the distal surface. So in general for canines, except the mesial surface, isolate from the first molar of the same side to the lateral incisor of the opposite side. When you are working on a premolar, for instance, I'm doing a cavity prep and restoration on a premolar, then how should I isolate? Whether it's class 1 or class 2. The isolation should be at least 2 teeth posterior to it on the same side, and obviously the lateral incisor of the opposite side. When I'm working on molars, then practically the distal most tooth or the distal most molar, right, of the same side and lateral incisor of the opposite side, right? I have done this in your recordings also. I wanted to repeat this as a quick revision of this MCQ from rubber dam, right, guys? Use of EDTA as an irrigant is all except. Very simple question. Sodium hypochlorite takes care of the pulp, that is the organic tissue. EDTA takes care of the inorganic tissue. That's your hydroxyapatite. That's your smear layer, inorganic component. So the answer is pulp dissolution. That is something that EDTA does not do. Just to mark the correct answer of the previous question, for your rubber dam clamp, you use the forceps, retainer forceps. A patient reported to the OPD with throbbing pain and swelling. The tooth was slightly elevated. Classic. There is pain, there is swelling. The tooth is slightly elevated, right? And mobile. So it's an abscess. Because it's symptomatic, the answer is acute apical abscess. Additional points, guys. The tooth will be non-vital. There will be radiolucency which will be present, right? So the answer is acute apical abscess. Which agent amongst the following is used to detect the calcified canal orifice? Now the best answer here is sodium hypochlorite. And this is known as the champagne bubble test. What is the meaning? Basically, when you pour champagne in a glass, bubbles elevate into the glass, right? Next important point. Then what does sodium hypochlorite do? So you have a case in which you have deroofed the pulp chamber, but there are calcifications and you're not able to locate the root canal orifice. So you simply pour, irrigate the pulp chamber, or you can submerge the pulp chamber with sodium hypochlorite solution. Where bubbling is there, because where it is where the tissue starts to get dissolved by the sodium hypochlorite, you get an idea that here the canal orifice with pulpal tissue will be there. So sodium hypochlorite, champagne bubble test. What is the next important MCQ here? The applied MCQ. In order to completely dry and clean the canal, once you've done your remove the pulp from the pulp chamber, now you want to see it, right? You want to see the anatomy. What is the best way to completely clean the pulp chamber? I'm not talking of the cleaning and shaping. I'm not talking of the BMP. What agent do you use which would completely clean the pulp chamber? The answer is sequential use of EDTA first, and then 95% ethanol. That's your MCQ. For what? The question is completely clean the pulp chamber for good visibility. Where are my canals, and so on and so forth. Step down technique includes preparation of canal in which direction? Now, guys, this is a very, typical question. First of all, if you read Engel, it says that more or less step down and crown down are the same, more or less. It's just that, step down technique was developed earlier in 1982. That was a time when nickel titanium rotary instruments were not introduced in the market. So the step down technique was basically started with H files and GG drills, right? And then you slowly, went deeper and deeper inside the canal. So obviously the order remains the same. You are going in a crown down manner. So the answer is simple, coronal to apical. Another important, so this answer is simple, guys, coronal to apical. Another question that comes here is, which causes a lot of confusion, is which of the technique leads to the least periapical extrusion of debris? And in that, if both options are given, which are more or less the same, which should you mark? Then in that case, I would suggest that mark crown down. That's a more modern technique, more methodical. In that situation, mark crown down. I hope I'm clear. Which technique leads to least periapical extrusion of debris? Crown down. But in general, if you're talking of step down, crown down, basically the same, coronal to apical. So first you prepare the coronal, then you prepare the middle third, then you prepare the apical third, and you enlarge the apical third to your master apical file. It's as simple as that. According to the law of centrality, canal orifices are equidistant from a line drawn in a mesiodistal direction through the center of the pulp chamber. This rule is not applicable to. First of all, there's a slight problem with the question here. In all your question banks, usually it's written the law of centrality. It's actually the law of symmetry, the first law of symmetry, right? So what is the first law of symmetry in the Krasner and Rankau rule states? This is my lower molar. That's my pulp chamber, right? If I draw a line right in the center, mesiodistally, of the pulp chamber, then my mesiobuccal and mesiolingual orifices are equidistant from this center. So this is 2 mm, this is also 2 mm. That's the first law of symmetry. What is the second law of symmetry? They are lying on a perpendicular line, right? Same with distobuccal and distolingual, equidistant and perpendicular. So that's the first and second law of symmetry. So this is applicable in more or less all of the teeth except the maxillary molars. Right, guys? That's your answer. So the answer is simple here. You have to memorize this, except the maxillary molars. Right, friends? So I think we had a very fruitful session. I'm very happy with this. I think I've tried to convey the important questions and the related concepts in a short span of time to make it crisp and interesting. Again, I wish you all the very best, guys. Take God's name, have full faith, trust yourself, keep working hard. There's no shortcut to success. Don't listen to pessimists and cynics, right? Stay optimistic, stay happy, keep working hard. Think everything will be great at the end of the day, and everything will work out, right, guys? Wish you all the very best. Thank you, guys.